Hello everyone, good evening and welcome to the 22nd episode of ICPA Clinical Series. The theme of ICPA Clinical Series is each episode one clinical challenge. And this time we have got a unique clinical challenge, and the niche area in dentistry is orofacial pain. And orofacial pain has been one of the most ignored aspects in dentistry as well as in dental practice. And to solve this dilemma or overcome this challenge, we are bringing you the foremost authority in this topic, an orofacial pain expert, Dr. Ruchika Sood. She's a graduate from Rutgers University, New Jersey, and she holds the diplomate of American Board of Orofacial Pain. And today she is regarded as one of the topmost authorities in orofacial pain management. She is a consultant to several top clinics in Mumbai, and she has been a national and international speaker. Today, she will help you to understand various types of pain in the head and neck region and the common mistakes people do in the diagnosis of such pains. She will also help you to incorporate and integrate orofacial pain management in your modern dental practice. She'll help you facilitate your patients with best treatments and participate in improving the quality of their life. And some key takeaways from her lecture will be to understand the types of pain. Is dental pain always dental, or there is another component to it? Is there any place for orofacial pain in your dental practice? Is every pain trigeminal neuralgia? How you can differentiate it? And is atypical facial pain as separate entity? This and much more from her rich experience that she has accumulated over the years. So I welcome Dr. Ruchika Sood. Ruchika, the floor
Thanks
is
a
yours.
lot. Thank you so much, Dr. Rajiv, for this opportunity and the warm welcome. And a very warm welcome to all of you uh, out there. Undekhe dost isse bolte hai, all of them, until we finish the presentation and I can see all of you. Our prayers to the God Almighty to may this be meaningful for each one of us present today. And my friends and my clinical mentor, Dr. Gary here, who made my training possible. So my heartfelt gratitude to them before I begin. How do you train for this subject called orofacial pain? This is the 12th specialty according to the US norms. And there are different courses that you can undertake as a master's degree program in the specialty in certain developed countries, one of them being United States. And that's where I trained at Rutgers. And I went on to do a lot of different courses with manual therapies and physiotherapy techniques. And I'm a licensed acupuncturist because all of these are required to manage the world of pain and bring relief to patients. We'll begin with a case today. And as you can see, this is a very young female. When she's come to me, she was 26 years of age. There's a sudden, sharp shooting pain. So we're going backwards, starting from 2008. There was a sudden, sharp shooting pain radiating to her head and ear. This started when she was eating a laddu post pregnancy. You know that gond ke laddu jo post pregnancy khane ke liye diye jate hain? Yeah, that is what she bit on, and she felt a sharp pain which was severe shooting in her teeth in the upper part of her head, and it would occur anytime and last for up to 2 minutes and disappear thereafter. It got aggravated by air, and she became extremely sensitive to even a thin hair in between her teeth. NSAIDs brought her relief. Okay. And then the first stop of 99% of the patients who visit our clinic is a dentist. And subsequently, also about 60 to 70% of the patients visiting our clinic keep visiting more dentists. So on an average, by the time I'm seeing a patient in the clinic, they would have seen about 6 to 7 dentists, and then the other specialists follow, which we will see as the case progresses. Okay. Please be sensitive to the fact that NSAIDs brought the relief and the patient felt the sensation of the stone. Okay. Now, this patient was referred to a neurosurgeon. There were not any investigations done, but straight away rhizolysis was done. And there were certain medications, neuropathic pain medications, which were given by the patient to the patient. Pain relieved for 4 years with recurrence thereafter. Okay. Now the quality of the pain has changed, but again, it was diagnosed as trigeminal neuralgia, and there were, plethora of medications that was given to the patient. This time there was no relief. So now we started doing the lab investigations. This started in 2008. This is 2014 that we are talking about. Okay. 6 years since, that's where we have started the investigations. The first time the MRI was done. Again, the procedures are repeated. At the trigeminal ganglia, no relief. This time, there is CT-guided lesioning of the left trigeminal nerve done and series of medications given. Few days of relief and recurrence thereafter. Okay. And then these are the medications this the patient is having in 2015, and a procedure repeated, which is ablation of V2 and V3 done. No relief. This is when we see the patient. Okay. Now here we see the quality of this pain, which has changed completely from where we started. This is severe hypoesthesia, numbness, and muscular weakness on the left side of the face due to steady flow of pain. And so much has happened in all these years to the patient, right? Because this is for the dentist, so let us get a picture of the teeth and see that everything is good there with the teeth. The periodontist can sure appreciate some inflammation that was present with the gums in the periodontal fibers. Is that significant? Yes, it is. For all pain patients, for all chronic pain patients, when the oral health is not good, especially when the gingival health is not good, it increases the intensity of the pain. So we should address it. These were the findings of our examination, and there is a provisional diagnosis with which we worked. We ran the blood work once again, and the final diagnosis of this patient was PTTN. This is a traumatic trigeminal neuropathy. Trigeminal neuralgia and trigeminal neuropathy are two different things. In this presentation, the only thing I wanted to bring to the surface and highlight by sharing this case is as dentists, let us take the responsibility of diagnosing the pain for the patients. The orofacial region or the trigeminal area is the territory of dentists. The first stop for most of these patients is a dentist. So let us as a community take up the responsibility of diagnosing these patients and understanding the differential diagnosis for orofacial pain at the first step itself. And that is where the change in the care for OFP will really happen. This is a different diagnosis than trigeminal neuralgia. This is a completely different approach to management and a completely different entity. So we worked with this patient based on the protocols of the neuropathic pain management, and it took us 1 month to bring the pain at 0 as reported. You can see the patient's form, and it takes a while for patients to get used to the neuropathic pain medications. And usually it takes minimum of 3 weeks for us to get optimal drug concentration with these medications. So sometimes when a dentist has referred a patient and we have written a prescription and there is no immediate relief and we say that it takes up to 3 weeks, please understand that these changes happen with the optimal drug concentration, and that takes time. So we should always be open to considering more options. Every pain that happens in this region is not trigeminal neuralgia. There are very many different types of neuropathic pains, and every one of them is not neuralgia. And let me also take a minute here to say that the pain which happens in the throat, or a sore throat which has been ruled out by an ENT, saying that this is, you do not have a ear problem, you don't have a throat problem, but still the pains persist, please consider ruling out temporomandibular joint disorders, certain myogenous disorders, and sometimes a joint disorder and the associated changes in the muscle will bring similar kind of symptoms. And I see a lot of patients who underwent treatment for glossopharyngeal neuralgia with this, and also with the changing times and increasing use of mobile phones, there is calcification which we see around the styloid ligament, and that also goes misdiagnosed with the neuralgias. Okay. So with this, I would like to bring your attention to the field of orofacial pain. This is that field which is concerned with the prevention, evaluation, diagnosis, and treatment and rehabilitation of orofacial pain disorders. The foremost authority for orofacial pain is American Academy of Orofacial Pain. You can log into their websites. There is a lot of information which is there about the programs, about the courses, and about the world of orofacial pain. And that's the appropriate source to go and read about orofacial pain. Okay. Now, what is it that an orofacial pain dentist does? Orofacial pain dentist manages many different types of problems that happen in the upper part or in this much part of the body. We have to be dentists to be able to understand differential diagnosis of the problems. But most dentists don't treat. Why? Because of limited understanding around the subject. That's where one of the first problems is. And each specialty is referring to each other. Okay. So what happens to the patient? The patient is running like a rat and hamster from one specialist to the other specialist, but not finding the cure or the solution to the problem. So there is a guided approach that an orofacial pain dentist takes, and there is also a time where we take a decision of not to treat the patient, and that is equally important as it is to treat the patient. This is a very interdisciplinary field and needs collaborative work amongst the specialties. Pain is generally just a metaphor for suffering. Okay, it means different things to different people, but according to IASP, International Association for Study of Pain, which is the foremost authority of pain, and that is another significant source for anybody interested in the world of pain to go there on their website and read about pain or their journal pain. Okay, so this is an unpleasant sensory and emotional experience. So when we talk about pain, we account for the emotional experience along with the sensory experience. Okay? Pain as an entity is essential for survival. Adaptive pain is a warning to protect the body from tissue injury. So we all need to be aware of, when pain is body's mechanism to bring attention to a certain part which needs healing at that particular type of pain. But that is about a pain which is adaptive in nature. Maladaptive pain is dysfunction. Okay? Dysfunction could be at various levels in the processing of the pain. Now, acute pain is what each one of you is dealing with day in and day out. It is caused by certain surgery, certain tissue damage, or, and it serves a purpose. When the body has undergone certain damage and you want to bring attention to it. It's of shorter duration, And the treatment has to be focused on bringing pain relief and cure for the causative thing there. Chronic pain, on the other hand, is a disease in itself. It does not serve any purpose. It may not be associated with any actual injury or disease. Focus on in this type of pain, focus of chronic pain is on management. So when we are seeing the patients in the orofacial pain world, we talk about management. We never talk about cure. We always explain them the management protocols and the journey that we have to undertake together for their recovery. In chronic pain, we talk about improving the quality of life, bringing them to an optimal function with whatever their present changes, making things better for them, giving them a better quality of life. It's a disease in itself. And a journey for healing begins with understanding. Understanding the knowledge of pain producing entities, of pain mechanisms, and the treatment strategies that are aimed at addressing those pain causing mechanisms. So, uh, management of pain is by listening to the patient and going backwards and understanding or deciphering what is it that we need to address in that particular patient. Okay. Painkillers do not offer solutions, and most of the people by the time they come to us have taken plethora of them. A lot of medicines, but no diagnosis. Painkillers do not work for all types of pains, but the appropriate diagnosis does. Okay? So I hope all of you are there with me so far. So why to be a dentist, to be an orofacial pain specialist? Because in this area, whenever we're talking about pain, we talk odontogenic first. Okay? It's very important for every facial pain patient to have a complete examination of the dentition. It's very important for the dentist to spare those 2 minutes and evaluate the problem of the pain, what you call 360-degree, or in a very comprehensive way. Because the case that we began our presentation today with, was it a misdiagnosis of a cracked tooth syndrome at the first time? Was it a cracked tooth which went undiagnosed? We don't know. Wedge test was never done. No dyes were inserted to read for the crack lines. No CBCT was ever done to evaluate that tooth if there were hairline fractures in that tooth. So we don't know. By the time I get to see the patients, they are really at the fag end. And most of the referrals to me are coming from the pain specialists or the neurologists. So what I am seeing in India as it stands today are really the cases who have been through everything. But as dentists, you are the first stop for the patients. Having said that, that is also the most difficult and challenging spot to be on. If you have to ask me, I feel it's easier to be at my spot and knowing that, oh, there has been so much of rule out that has happened with this patient, and now starting to think to manage that patient. But when you see that patient for the first time, and then you have to establish the differential diagnosis, that's indeed a challenging spot. So we need to spare that time to evaluate the patient. When we talk about OFP, we categorize it broadly into 3 types: musculoskeletal, neuropathic, and neurovascular. Temporomandibular disorders are a type of musculoskeletal pain, and they're spoken about a lot. It's a unique joint because it is a glenoarthroidal joint, a joint which rotates and translates. Most adaptive joint in the human body, a joint which rarely needs surgery, which has a very poor prognosis with surgeries, and very few indications where surgeries are required in human body. So, as it stands today, based on the guidelines, which are RDC guidelines for the management of TMD, based on evidence-based dentistry guidelines, uh, based on the consensus which exists with all board-certified orofacial pain specialists. There are certain conservative treatment approaches which are taken for the management of temporomandibular joint disorders, and that is what we practice at Neocare and recommend practicing as dentists. These are the symptoms that most of you would be seeing in your day-to-day practice, and you know, these are the warning signs for a temporomandibular joint disorders and need very guided investigation. We'll see through one of the cases where the patient came with preauricular area pain from zygoma to angle of mandible, headaches, and neck pain. So these are three different types of complaints in one patient. Keeping the history small, see, by the time I have seen the patient has seen multiple doctors again, ENT specialist, neurologist, pulmonologist, and six dentists. He was referred to me by the ENT specialist. Okay, and his pain has been getting worse over the years. When we examined him, we found a couple of findings which are there in front of you: lymph nodes, palpable, certain trigger points in the muscles, and the joint which is deflected to one side. On investigations, we found that, yeah, there were degenerative changes in this patient, and there were also other things, which was thyroiditis and cervical lymphadenopathy. So when we see a temporomandibular joint patient, we have to understand is what is it that is bringing that pain. There are enough publications on systemic pain, systemic causes of orofacial pain. And I really want to emphasize that at this platform today, because I had seen one of the patients few months back, which was the referred pain of a tumor, and patient was with multiple dentists, and nobody considered it to be a referred pain of a certain type of a tumor. By the time I got to see the patient and then I started investigations, and the patient completed the investigation in 1 week, and I could refer him for oncocare, we had lost him within 2 weeks. So from the time patient walked into my office till he left the world, it was 3 weeks of time. We took 1 week to complete all the investigations and refer the case. But the patient took 2.5 years of visits to dentists. And then pulmonologist had referred him to me. So as dentists, we are doctors. We are not carpenters. We are not certain mechanics working on drilling of teeth all the time. We need to take our responsibility with a little broader horizon. And there are enough publications to support that there are systemic causes for orofacial pain. And I see a lot of them on a regular basis. This is just one of those cases. And a lot of autoimmune problems. They present as orofacial pain problems. A lot of movement disorders. They present as orofacial pain problems. Also the motor neuron diseases. There also we see a lot of stiffness and difficulty to eat in terms of orofacial pain problems. In fact, my motor neuron diseases patient inspired me to take training in palliative care on how to manage them. Okay. So what we did for this patient is acute therapy with ultrasound, pharmacotherapy, and splint. And yes, we worked with a physician to manage the problems with the thyroid. This is his testimonial, which you can keep hearing. I know this presentation is going to stay up. So this patient has found relief after 10 years. And this was a case we did few years ago. And
बरेच झाले 10 वर्ष झाली पण नंतर मी भोबे डॉक्टरांकडे गेलो त्या डॉक्टरने मला तुमचा नंबर दिला.
Dr. Bhobe is the referring ENT specialist for this doctor. This
great.
patient. So you can hear that testimonial on our social media platforms also. But this patient is still our patient. So this is 4 years ago, 5 years ago. So this is about chronic pain. This is about chronic pain. Why is he still our patient? If we had brought his pain to zero, why is it that he keeps getting these flare-ups? Because once the function is restored, he loves to exercise. He loves to be, he's a regular at gym to the extent of lifting 100 kgs. So a person who has a degenerative joint and wants to exercise to such a limit, is it possible that he will pull a muscle here and there? Yeah. Is it possible that he's a foodie and he loves to eat based on the season, and if you eat a lot of food which you're not supposed to, or if you party too hard, you will get a flare up with your pain? Yes, we will. All the existing pain patients experience those changes and they stay under the care. That is about the world of chronic pain or the orofacial pain, that we maintain the quality of life for these patients and they function comfortably. This brings us to myofascial pain. We have all heard about it and very commonly diagnosed by a lot of people. The controversy in this is that the source of pain and the site of pain is usually not the same. So that is the challenge of myofascial pain. And considering the time restrictions, I'm not going to spend a lot of time on that. The trigger points refer pain, and based on the referral pattern of the trigger point, patients will experience the pain. What I do want to mention though is, as you can see here, the trigger point of the masseter muscle is coming on the teeth here. Okay, trigger points of the temporalis muscle, they come on the on all the upper teeth. So based on what muscle has developed the trigger point, a lot of times patients will have pain in their teeth when there is no obvious pathology on an IOPA. Please do not do a root canal. Because patient has unexplained pain, do not do a root canal. I see patients every day where a root canal has been done because there was pain, and still now the pain is not addressed. You know, with the causative reason is a trigger point, the pain will not resolve after a root canal therapy, but now we have caused a minor neuropathic trauma. So the pain may increase, the pain may change its, presentation. So if there is no obvious pathology, a root canal is not to be undertaken. So neuropathic pain is the pain with the nerves, central nervous system, peripheral nervous system, autonomic nervous system. Everything will bring pain in this part of the body. If we have a pimple, it's such a significant thing happening to our life. But if there is a boil on the leg, you will walk through your day comfortably and live comfortably. Why this difference? Because the autonomic nervous system is working differently with the face. So anytime the patients have pain in this part of the body, it is intense. It means something different to an individual, which is including ourselves. This is a season of allergies. We can have allergy anywhere and we will pull through the day. But an allergy on the eye, which swells up the eye, you will take a day off and stay at home and not want to interact with people. So patients are not psychos. Like, I get a lot of my colleagues calling me something like, see if you can do something, malatak the psychos what to. I hear it very, very commonly. But in 13 years, 2023, so many years of being with the world of pain. 15 years of being with the world of pain. I have not seen a psychological patient the way it's been described. Yeah, there are hypochondriacs. Yeah, there are certain comorbid conditions, but they also need to be diagnosed appropriately and taken into the complete treatment plan of the patients. Of late, we also see patients who have been on anticholinergics, on antipsychotics, and then they will have burning in the mouth. So the history of the patient is extremely significant. When the painkillers are not bringing relief to the patients, it's a sign that it is neuropathic pain. The pain is being sustained by the nerves. So there are a lot of mechanisms by which neuropathic pain is maintained in the body. And then we have neurovascular pain. We are a orofacial pain relief center. We change from headache and facial pain because whenever we try to work around headache, for many years, I came back from US for good in 2016. And this is so for many years, for 5 years, we tried to do headache campaigns, because when I would interact with people, I would hear a lot of times the same problem of headache. And in a headache camp, yeah, people would walk in because they would be curious to know a little more, maybe, but nobody walked in seeking treatment. The self-conscious, accepting, and tolerant community or a nation that we are as Indians, headache is considered as normal. And this was a big surprise to me after having spent many years in US, that headache is considered normal. And even if a patient is coming to seek treatment of headache, it is only when it is blown out of proportion. The other fact about headaches is that headaches are synonymous with migraines. The migraines are one of the types of headaches, but here for most of the people, they are synonymous, whether they have a headache or a migraine. There are very many different types of headaches. Dr. Benoliel has spent very many years of his life, up to I think close to 36 years, on working with neurovascular pains. And he has published, there is international, he's one of the pioneers or key people there for the ICPA classification, International Classification of Orofacial Pain. And these resources are freely available online, and you will get to see a lot of types of neurovascular pain. And the mechanisms by which the pain happens in the head need to be understood by the orofacial pain specialist. Has to know it. There is no two ways. But a dentist can have a fair square idea about it. Why? Because of cases like these.
शुरू से मुझे एक बार वापस से बताइए, यहाँ पे जो दर्द है हाथ लगा के बताइए कहाँ पे,
you will see
कब से है,
that they have pain for
नॉन स्टॉप
years
है ये दर्द,
together.
2 साल से रुका बीच में ये दर्द,
Years together. That the patient had pain.
4 दिन रुकता है,
And she's only 40, but had to undergo
इन 2 साल में इस
total
दर्द के लिए आपने क्या क्या किया?
extraction in 2 years.
दवा ऊपर से मलम अंदर से सब कुछ लगाया, बहुत सारा उसका बॉडी का कागज नहीं, मगर वो सब है
So this is a complete recorded history, which you can definitely take 10 minutes and listen to when the presentation is uploaded on the ICPA platform. But the diagnosis in this patient is facial migraine. It is possible that headaches, migraines present as facial migraines. You saw the place where that lady was touching as the pain area. She'd been to many dentists. She could not get a denture also. Total extraction has been done for her. Attempted suicide because of unbearable pain. Survived and somehow reached me. All it took was a combination of medications and then maintain her on a dose of beta blockers to find her total pain relief. So if there is a pain in the tooth, the source can be somewhere else. We have to have an open mind for it. She also had autonomic cephalgias along with the facial migraine, which is a different type of headache disorder. So to conclude, I would say that pain presents in different parts of the face for any of these reasons, musculoskeletal, neuropathic, or neurovascular. And as dentists, we need to be aware and understanding of these problems. Tongue movements, the floor of the mouth, these need to be checked very, very diligently. And the approach for treatment or healing of these patients is based on the biopsychosocial model and covers a lot of different therapies and addresses the pain as a disease state to bring function and quality of life to the patients. As doctors, it's very important that we do no harm to our patients. It is very important to understand when not to treat. Okay? And that happens only when we understand the history, we know how to arrive at the right diagnosis. Diagnosis is the key. And these are the words of my mentor, Dr. Gary Hare, who always used to say, you cannot diagnose what you don't know, and you cannot find what you don't look for. So be always on a lookout. It's as an orofacial pain specialist, our job is like Sherlock Holmes. We are always, finding reasons, finding solutions, or looking for the clues in our patient management. And also, it's like the onion peel, where you treat layer by layer, and eventually, by God's grace, so far we've been able to get decent results. You can look at our patient testimonials on Insta handles, FB, and you can reach out to us to know more. So with this, I conclude, and my heartfelt gratitude and thanks to all the people who have made the possibility, who have contributed to the making of Dr. Sood and who support this journey. And thanks a lot today to Dr. Rajiv Chitkupi for having me here and the ICPA platform for hosting this today. These are all my teachers, Dr. Gary Hare, Dr. Eliab, who is an authority with neuropathic pain, Dr. Stanley Markman, who worked very hard to keep the dentist in me alive, and Dr. Siveli, who is an authority with burning mouth syndrome, and also one of my research mentors, along with Dr. Elia. And that's my daughter. So with this, we are ready to take the questions. And thankfully, there is no blackouts that are happening here, but we've done okay with time. So over to you, Dr. Chitkupi.
Thank you, Ruchika. It was a fantastic presentation. Not an easy topic to cover in such a short time, and there are so many facets to it. Even I could see the different paths you took in different patients. Such long time, 10 years. Somebody got relief after 10 years, And one important take-home point for me was there is no psycho patient. There is no
Yes.
need to blame the patient that the patient is psycho. There is always an organic cause. You have to identify that and you have to treat it. That's what orofacial pain is all about. So one has to be like Sherlock Holmes, and don't stop your journey or inquisitive journey of finding the real cause and then coming to our what you can say, treat the cause rule of medicine and the rule of healing. So
Yeah.
let me take some of the questions sent by registered participants. There are how to manage patients above 40 years with orofacial pain because of improper anterior guidance occlusion.
So, my colleague, Dr. Maithili Kalatka, has a publication on temporomandibular joint disorders and occlusion. And I recommend that all the dentists should read it once. Dr. Maithili is practicing in Bangalore, and she's also an ABOP. She's also diplomate from American Board of Orofacial Pain and works with the philosophies in philosophy. So it will give a lot of understanding on occlusion and temporomandibular joint disorders. Temporomandibular joint problems can create occlusion problems, yes. So as a sequel to a joint problem, an occlusion problem can exist. Usually it doesn't happen the other way. Okay, so the question that what is challenging the age 40, I don't know why the person who wrote has pointed out this age 40, but yeah, this in pain management, it is very significant. The age 40
Okay.
is significant, and it is significant because of now this will get a little complicated, because this is, to make it simple, when there are two stimulus given to anybody, right? And if this is a finger which is cut by knife, and I dip this in hot water, and I ask you to rate the pain, and you say 4, and I remove the hand from the hot water and ask you, what is the difference? What is the number you would give to the hand which is cut by knife? And you say 6. Now there is a difference in this reporting with the pain. Why is this difference there? Why is it that if one hand is in hot water, the same cut finger is paining you less as compared to the earlier time? So this 6 minus 2, this is your modulatory capacity. This is each individual's modulatory capacity. In the world of pain,
Modulating
it is
capacity.
modulatory capacity. In the world of pain, it is called as conditioned pain modulation, CPM. So the modulatory capacity changes at the age 40. That is why this difference, this age becomes significant. So if there is somebody who is seeing that there are a lot of challenges they face in this, I really recommend that you read a little more on these aspects, read a little more on yoga and exercise induced analgesia, and you will be able to find better results. Don't look at finding solutions for the pain problems by managing teeth.
Okay.
Pain
Thank.
problems are pain problems.
Okay. Relevance of hotspots and trigger points in MPDS.
So I think we covered that in the lecture. The trigger points
Yes.
are
Yes.
the
Yes.
points from where the
Yeah.
pain is getting referred,
Yeah.
and we have to diagnose it. What is the muscle where the trigger point is, and then treat it appropriately with the right medications. Depending
Okay.
upon the intensity, it may be drugs like cyclobenzaprine or nortriptyline or amitriptyline. those are, we have to really go over the complete history and then decide what drug to take.
Okay. What is your recommendation for neuralgic pain management in a pregnant patient?
I haven't seen one yet, and the the nature has very strong pain protective mechanisms in pregnancy. So usually pain problems are limited in pregnancies. If somebody is experiencing that kind of pain in pregnancy, we really need to look at diagnosis. Neuralgias are also usually seen in a plus 50 population, and pregnancy will happen in an earlier age group. So diagnosis is really, really, I strongly say that please do not go by the diagnosis that you hear from the patients. Take the history and work out the diagnosis yourself.
Okay. Okay. Next question. What is your opinion on bilateral balanced occlusion splint in treating painful anterior displacement with reduction?
So there are very many types of splints that are made. Stabilization splints are most studied and most commonly done and known to give very good results. So we stick to that at our office, and most of our work is with that. And if you are going to talk about disc displacement, we have always worked with stabilization appliances, and that is the recommended protocol.
Okay. How to manage long span neuralgia and paresthesia in post-operative surgical extraction, mandibular nerve damage?
Okay. Again, this word neuralgia, post-operatively mostly it's okay. Neuralgia happens sometimes. Is it episodic pain or is it constant pain? I would like to ask the person who's put this question. I'm sure you are listening. So try to think through it. Is it episodic pain or is it a continuous pain? Neuropathy and neuralgia are two different entities. What happens post extraction is mostly deafferentation pain because of sustained neurogenic inflammation along the track of the nerve.
Okay.
So deafferentation pain is managed by, again, neuropathic pain medicines. These are serious medications and should be attempted only after appropriate training. So most commonly, I do come across prescriptions where all possible neuropathic medications are given to patients. Gabapentin, duloxetine, pregabalin, give everything. But what are you making out of a patient? A chalta firta zombie? Somebody who cannot drive, somebody who cannot do anything. So have we made the quality of life better for that person? So generally, paresthesia, which will happen, is in this limited zone. And so we need to understand that. And at NeoCare, we do therapies, which is one of the therapies is electrotherapy, which has given us very, very good results. And I think almost every dentist can train themselves on that. It's just about becoming aware of that these are the options that exist and train yourself for that these therapies are about understanding how to work with the frequency and amplitude and bring about the neuromodulation through the dermal receptors, or how to work with the basis of the HP axis. Anybody who has studied physiology in dental school has taken the second year subjects more seriously. Yeah, you can invest just little time and learn all these therapies for the dental applications, at least for the applications like these.
Okay. And there is a question, is there any role of acupuncture or acupressure in managing neurological pain?
Yes, there is. I'm a licensed acupuncturist for a reason.
Okay.
But not many people, when they come to allopathic doctor, they're not really keen on acupuncture as a treatment therapy. But that's been my experience. That's just experiential I'm talking. But when I talk evidence-based, yes, I do see acupuncture plays very, I'd say, has a good place for very many different types of therapies. At NeoCare, we are a multidisciplinary center. Multidisciplinary means where we are working with different. I use the word interdisciplinary in my talk. Orofacial pain is interdisciplinary because a periodontist has a role, a prosthodontist has a role, an oral medicine person has a role, and OFP person has a role. But at NeoCare, when we are an exclusive pain center, we are a multidisciplinary center. Because an Ayurvedic doctor has a role, an acupuncturist has a role, a counselor has a role, a nutritionist has a role, and an OFP doctor has a role. So acupuncture brings in immediate relief. So these are chronic pain patients. So how it works, see, this is now springtime. This time, liver meridian gets affected very commonly, and there will be blockages in that energy. This is the time of change of energy. Acupuncture is about flow of energy, yin and yang. It's a flow of energy. So spring is the time of change in the flow of energy. And according to acupuncture, that is also one of the reasons why there are allergies in this season, the blockages with the liver meridian. We should eat lighter for about these 2 to 3 weeks and follow. So yes, it has a role. And neuropathic pain, it does help because it breaks that flow, helps us get immediate release in that flow of energy. And then we support it with our medications, which take about 3 weeks for the right drug concentration to come up. And then we manage the patient on that.
Okay. Is there a way to manage acute pulpitis other than the conventional root canal treatment?
That's a better question for you, Dr. Rajiv. I haven't looked at acute pulpitis in years together. So I don't think I'm the right person to answer that one.
Okay. What is your experience with opioid drugs in orofacial pain management?
So we used to see a lot of these patients in US. I think opioids are underused in India.
Okay.
There is too much of taboo associated with them. And they do have a place and role in chronic pain. And I would just share one case with you to set a perspective that we had an existing patient of temporomandibular joint disorders and disc displacement, anterior disc displacement with reduction. And this person also had an associated sleep issues. We could sort out everything, bring everything back to normal. A young guy, so he said, okay, let me now do the aligner treatment.
Okay.
So when you do the aligners, though there is mild evidence, but there is an evidence with myalgias. Because of the existing history of chronic pain and the lifestyle, or to say the work schedule, these people were not responding to any of the NSAIDs for that pain. A short duration opioids, yeah, did help. In case of neuropathic pain as an adjunct to reduce the dosage of the other medications, yes, it is used. There is a place for opioids. It has to be used judiciously. That is important. That is important.
Can a previously detected tooth fracture lead to long-term orofacial pain post-extraction?
There can be orofacial pain post-extraction, irrespective of the fact whether the tooth was fractured or not.
Yes, absolutely.
So post-extraction, what we get is a deafferentation pain.
Okay.
And how I really feel that the first case that I saw was a cracked tooth syndrome. Okay. So, and see, I see only the end of the road cases, but I really feel that fracture of the tooth is one of the things जो most of the dentists मुझे लगता है कि मतलब उसको ना हल्के में ले लेते हैं, कोई सोचता नहीं है ज़्यादा कि wedge उठाएं. You know, there is a wedge test जो dental college में सिखाया था. Please use it. there are dyes that people can put today and see that, there is a possibility of a cracked tooth there. So use it for
Okay.
that.
So any role of physiotherapy in orofacial pain?
Yes, physiotherapy has a lot of role to play in orofacial pain problems.
Yes.
And a lot of physiotherapy techniques are used. Now, again, what is to be used is again dependent on the diagnosis. Certain patients may trigger point injection is required. If it's a firing, referring trigger point, you will give an injection, block the referral of the pain, and then request the physiotherapist to release the trigger points and bring the harmony to the patient. The certain times when you have more of mechanoreceptors based pain, which is in the fascia, you would want only the manual therapies to be done on a patient. So physiotherapy has a very, very big role. And especially, like, you can see where as I'm sitting not sitting straight. This is not right. The posture should be like that, right? But just the way I made the adjustment to get with this screen, I've raised my couch, so I'm not able to sit straight. This is common. मतलब इंसान बंदर बन रहा है. And because of that, we see a lot of muscle related pain in this part. Everything is interrelated, right? So and the fascia is a common layer from your head to toe. So physiotherapy is a very, very significant part of the
Orofacial pain management. Okay. How do we screen a patient with orofacial pain? For a beginner, what he should be doing in every case. Now, they don't want to miss a single case. So what are the initial steps?
You know what, we will be putting up a YouTube video on our website very soon on how to do this screening, because this screening in itself is a minimum. See, history taking and everything was 45 minutes to 1 hour it takes in our office to us today. So as a beginner, तो हम 3-3 घंटे एक ही patient के साथ बैठे रहते थे. That no dentist can do. So what is practically possible for a dentist is to develop a schematic list of common differential diagnoses. So if somebody is complaining of pain in this part around the temporalis tendon part, okay, please evaluate the periodontal health around 6 and 7.
Okay.
Maybe, yeah, that is something I have to mention today, right? With periodontist sitting here, that periodontal fibers have motor receptors which will report at the motor nucleus, and the masseteric nerve is also the motor nerve supply. So I see very, very commonly dentists referring the patients to neurologists or the pain specialists, patients undergoing procedures, pain not being resolved, and then they somehow find it.
Okay.
So the perio evaluation has to be a part of dental office before orofacial pain evaluation.
That's
Periodontal care or gum health is a very important part of human beings. The oral health, it's very, very important part of our health. And it is most ignored. Calculus is considered normal. Periodontitis is okay. Teeth falling on its own in the old age is a joke. You don't want to go. A mobile tooth, if rebuilt, if appropriate therapy is done, may live another 3 years, may live another 5 years. But as dentists also, people are not thinking about those things. That is important. And then what else you can do to screen with orofacial pain is like differential diagnosis. If there is no periapical pathology, then no root canal is to be done.
okay.
TMJ disorders, when we see, they are joint problems. They cannot be fixed by treating the teeth. We cannot, increase the vertical and address the condyle into a different position, and a lot of things happening like that. No, the joint is to be treated like a joint. You know, when it is about a knee joint, do we start treating the foot to fix the knee joint?
Agree.
We don't. That's how TMJ is a joint, like a joint in the body. And we sure will put up this video. We'll make one in about a
Great,
week or 10
great.
days.
Thank you. How effective are anti-epileptic drugs in the treatment of orofacial pain?
All the drugs are effective based on the diagnosis. Diagnosis.
Great. Perfect. Role of dry needling in terms of orofacial pain.
So dry needling is one of the modalities in physiotherapy practices. But as an OFP doctor, we do more of trigger point injections, which do not bring soreness to the muscles, are more comfortable and convenient for the patients. All the therapies are effective based on the diagnosis. What is to be done for which patient and for what diagnosis is important. You know, mind, body, and soul.
Yes.
It has to be, patient has to be evaluated as a whole. There are people who have immense patience and TK, they have all the time in the world. A CEO will give 100% compliance to non-invasive therapies, but a CFO has come to you, will not. He has no time. His life is always on fire. So depending on the patient and the diagnosis, you have to decide your treatment.
Okay. So I think this is the last question I'm taking up. Does mandibular rotation cause TMJ, ear, neck, shoulder, and back pain?
I really think this question is really not framed in the right way. Rotation and translation are just the types of movement with the joint. So movement of the joint cannot cause any kind of pain. So, you know, what somebody means is that the joint is going to rotate and then translate, right? So rotation by itself cannot cause it. If there is pain happening with the movement in the joint, we need to figure out what's wrong and what's happening with the joint.
Okay, perfect.
And TMJ disorders can cause all of that, yeah.
Okay. So I think we have successfully finished all the questions sent by our registered participants, as well as all the questions that were sent by our live viewers. So thank you, Dr. Ruchika Sood, for enlightening us with your topic of expertise, your core domain, orofacial pain management. Thank you so much for patiently answering all the questions. I think there is a person who wants to know, is partial edentulous condition a causative agent? Partial edentulousness for more than 5 to 7 years leads to orofacial pain. Is it a rule?
No, there is no rule like that. There is no rule like that. Every patient has to be looked at in totality. If there are missing teeth, can they have an impact on how you are eating your food and how you are biting? Yeah, of course, it will. You cannot forget your TMJ and then your oral full body. I think Dr. Maiker is on a mission this day that if you don't have teeth, you cannot have health. You know? So very soon, everybody in India will be seeking teeth because the man is on a mission that if you don't have teeth, you don't have health, which is a fact. If you can't chew your food properly, 50% of your digestion has not happened. So if that is the reason that the food is not getting digested properly and it is not getting absorbed properly, is that food going to create inflammation in the body? Yes, it is. So it will not only be this part, there will also be other parts where that patient will have pain. Knee pain, ankle pain. There will always be other parts also where that patient will have pain.
Okay. Let us take one last question. Any condition other than trigeminal neuralgia in orofacial pain, because it is common in after. Can you read the question yourself?
Yeah, I can. Is there any other condition except trigeminal neuralgia and orofacial pain because it's common after 50? See, trigeminal neuralgia is just one of the conditions. What is the reported incidence? Please read it in the literature. When we were students, I think it was 3%, 5%, very little. Might have increased or decreased, whatever. Its incidence is this much. How come we talk so much about it? Because trigeminal neuralgia and atypical facial pain were the two entities most spoken about. We do not have, we cannot look for what we don't know.
Yes.
It is only about that part. Trigeminal neuralgia is not as common as I think it is believed to be. And also, what another challenge that we experience is, even if I diagnose this patient is not a trigeminal neuralgia patient, doesn't need Tegretol, that patient is not going to wean off Tegretol, because Tegretol is one of the best mood enhancers. So for that reason alone, it's extremely difficult to wean patients off of the tablets. So there are a lot of conditions which are there in orofacial pain, and you can definitely go to American Academy of Orofacial Pain, read patient resources. You can look up the professional resources also on their websites. My website is there. Dr. Maithili's website is there. Yeah, those are more reliable resources. It's very important where you are reading. You can read publications in Journal of Oral Rehabilitation, Pain Journal, Journal of Pain, Journal of Movement, AAOP. Just type them, it will show you up. Yeah.
Okay.
And I think there was one more thing, the atypical facial pain, is it that common? No, it is not. It is not.
Yeah. There is another question.
Yeah,
Atypical
it is
facial
not
pain.
facial pain. Atypical facial pain is a rarity. And there were times when much was not known about orofacial pain. And that is when a lot of things were written as atypical facial. Today, a lot of research has been done. We have a lot of guidelines 2020 and onwards. So atypical facial pain, JCTs, is really, really rare. And to be honest, I have not seen even one patient of atypical facial pain in 15 years. We're always able to put our hands on what's wrong and how should we approach it.
All right. Thank you, Ruchika. Thank you for answering all these additional questions as well. So that brings us to the end of episode 22 of ICPA clinical series. Each episode one clinical challenge, and today we had orofacial pain, and the best person to speak on this, Dr. Ruchika Sood, MDS orofacial pain from Rutgers University. So thank you
Thanks a
everyone
lot.
for joining in live and actively participating, asking questions and bringing all those questions to everybody else's attention and getting the best answer from the expert. Thank you so much. Soon
Thanks a
we'll be
lot.
announcing the episode 23 of ICPA clinical series. Soon you will hear from us about the new topic and the new speaker. Thank you,
Thank
Dr. Ruchika. Thank you, everybody. Good night.
you.